can start sharing your screen.
Thank you, Celine, and thank you, Hassan, for inviting me. I'm very flattered that you had even heard of me, actually. So it's a pleasure to be with you, and hopefully one day it will be in person. So what I would like to title this talk is really, how does doing research, basic science research and clinical research about syringomyelia, how does that actually impact on how we manage the condition? And that's how I'd like to frame this talk. So I'll go through some of our basic science research and then the clinical application of that. I don't have any disclosures to let you know about. So you all know that syringomyelia is really not a condition on its own. It's something where it is usually secondary to something else. Chiari malformation, spinal cord injury. And this list is not complete, but if you can think of it as being congenital or acquired, and conditions at the craniocervical junction or conditions in the spine. There's a very broad range of conditions that result in syringomyelia, and down the bottom here I've put idiopathic, although that's probably a large number of patients that we see. But really, we can bring it down to this shorter list, which is craniocervical junction abnormalities, and the archetype, of course, is Chiari malformation, but it's not the only craniocervical junction abnormality that causes syringomyelia. Spinal cord injury, arachnoiditis from trauma, infection, previous myelograms or surgery, and then the leftover ones where we don't find an underlying cause, but presumably there is one. We just can't identify it. And so that's why I put idiopathic in inverted commas, because I think as we get an increased understanding and increased imaging capability, the patients who are classified as idiopathic will become a smaller proportion of this group. If you look at, I know that all the neurosurgeons recognize that syringomyelia is a certain type of condition, but it always strikes me that neurologists and other doctors just don't quite understand what syringomyelia is. And I think that's because when we go to medical school, if you read a neurology textbook, you get this kind of description, which is destruction or degeneration, cavitation, implying that it's this kind of passive thing. And if you look at post-mortem images, then there's this cavity in the spinal cord. I think that's what probably neurologists think of as this cavity. And of course, here on the left is a normal spinal cord, and the central canal is this tiny little thing here. But I'm sure all of you know that when we see syringomyelia, it looks like this. Right? So in this cross-section, the syrinx is really enormous. Of course, if you saw that patient, that spinal cord post-mortem, the syrinx would collapse and you would see it like this image on the right. But in life, it's really quite different. And these images, I think, really illustrate that. This is I think, illustrating how incredibly dynamic syringomyelia is. And the image on the right is a surgical case of post-traumatic syringomyelia. This is syrinx fluid coming out. So it's not a passive cavitation and accumulation of fluid. It's a passive, it's an active, very dynamic condition where the syrinx is often under high pressure. We have a better understanding now of the actual pathology. So in the past, it was thought that most syrinx cavities were like this, with communication with the fourth ventricle and then expansion of the central canal. But we now understand that the majority of cases, particularly those associated with Chiari malformation, do not have a communication with the fourth ventricle. There's an occluded section of central canal. And then it is the expansion of the central canal that forms the syrinx. But in post-traumatic cases and arachnoiditis cases, the syrinx cavity begins outside the central canal. And that's important because it leads to an understanding or an appreciation of how they present clinically. So these are some examples. So non-communicating canalicular syrinx in association with Chiari malformation is an expansion of the central canal. And so the spinal cord tissue is not actually disrupted. It's not like a replacement or destruction of that central grey matter, which those neurology textbooks would have you believe. They would have you believe that a syrinx like this is somehow damaging the central grey matter and getting those crossing spinothalamic fibers. Whereas in fact, it's really more like hydrocephalus, where the spinal cord tissue is expanded, but there's not actually any damage to the spinal cord. And so a patient with this type of syrinx can actually be asymptomatic from the syrinx. And this is from one of our experimental models, but just showing that that sort of cavity is lined by ependymal cells and the spinal cord tissue itself is undamaged. Whereas if that syrinx cavity breaks through the ependymal lining and starts to damage the spinal cord tissue, that's when it becomes symptomatic. So in this case, that's the expanded central canal. This is where it has ruptured through, and generally it ruptures through into the dorsal horn. And so this is where a patient becomes symptomatic. And a small extracanalicular cavity. So when a syrinx cavity starts outside the central canal, and here's our experimental model showing normal central canal and a syrinx cavity outside, then that is damaging the spinal cord tissue, and that person will be symptomatic. And so here is a person with a very small syrinx cavity, but because it's outside the central canal and in the dorsal horn, that person is very symptomatic from what is actually a very small syrinx. And we're taught in medical school that central cord abnormalities get the crossing spinothalamic fibers, and that's why we get this suspended cape-like sensory loss of pain and temperature loss. That's not actually what happens in syringomyelia. It's actually different to that. What happens is that the syrinx cavity breaks through, like this case, into the dorsal horn. So it is this location where the damage to the spinothalamic fibers occurs, not in that ventral crossing location. That's not where it occurs. It's here. And so it can be unilateral. Commonly, of course, it's bilateral when that dissection into the spinal cord tissue occurs on both sides. But it is this location where the damage occurs. And we can see that on MRI. On MRI, those kind of cavities that are still lined by ependyma are generally not symptomatic. And so it's only when an MRI shows this kind of picture that we can be confident the patient is actually symptomatic from the syrinx. And then we come to, well, how does a syrinx form? I mean, we know that it's related to all these different conditions. And so there's got to be something that is causing the fluid to accumulate inside the spinal cord. And broadly speaking, we can divide the kind of concepts of how this might happen into hydrodynamic theories and non-hydrodynamic or other theories. And by hydrodynamic, I mean that the flow of CSF in the normal CSF spaces and how it might get into the spinal cord. And I'm sure you're all familiar with the original theories of Gardner, who suggested that the arterial pulsation forced CSF through the central canal into the spinal cord in the presence of Chiari malformation, because the Chiari malformation was blocking the outlets of the fourth ventricle, and that the Chiari malformation would then actually squeeze the top of the spinal cord and prevent CSF from getting back up into the fourth ventricle. Or the slightly different theory of Williams, who said that when you coughed or sneezed, you would push CSF from the spinal subarachnoid space up into the head. And then when the Chiari malformation came back down into the spine, the CSF couldn't get back into the spine through the same way. And the only way it could get back into the spine was through the fourth ventricle and into the central canal. Well, we know that both of those theories are wrong. And that's because the central canal is actually tiny. And most of the cases of syringomyelia in association with Chiari malformation are a very long distance from the fourth ventricle. And you can demonstrate using physical principles that it's just not possible for CSF to be coming from the fourth ventricle to enlarge this kind of syrinx cavity. Having said that, there are some cases like this one where it is actually communicating, and you can't necessarily appreciate that on an MRI. We can appreciate it at surgery with an intraoperative ultrasound. But this is the kind of case that we see when there is obstruction of the outlets to the fourth ventricle. So there will be Chiari malformation, but also perhaps a membrane across the foramen of Magendie, or compression preventing CSF from getting out of the fourth ventricle. And this is a communicating syrinx. Often these are small and very symptomatic because they enlarge in that location and break through that ependymal lining and cause damage to that upper spinal cord. And so this kind of syrinx we can identify from the MRI as communicating, and even though it's small, will often be symptomatic. Whereas this type of syrinx is often not symptomatic. And then there are the alternative theories where the original theory of Ball and Dayan suggested that with coughing and sneezing, CSF was forced through the spinal cord because of an increase in pressure in the spinal subarachnoid space. And then more recently, Ed Oldfield suggested that that increase in pressure in the subarachnoid space was coming not from coughing and sneezing, but from the normal arterial pulsation, pushing the Chiari malformation into the spinal subarachnoid space, increasing the pressure in the subarachnoid space and pushing fluid into the cord and expanding the central canal. Well, we know that can't be true either, because if you have a pressure on the outside, it can't make a cavity on the inside expand. That's just impossible, physically impossible, right? So an increase in pressure on the outside of the spinal cord would tend to collapse it, not make it expand. So it can't be that. And another piece of evidence against that is that sometimes, of course, we treat a syrinx cavity with a shunt. And in this case, you can't actually see the shunt tubing, but there is a piece of shunt tubing going from the syrinx cavity into the spinal subarachnoid space. If this was caused by pressure changes in the subarachnoid space pushing CSF into the cord, then the shunt would just make it worse. Whereas, of course, what happens is the syrinx collapses. So we can be quite confident that it's not that simple transmission of pressure from the spinal subarachnoid space. And then there are some other, perhaps more complex theories about obstruction of fluid getting out of the spinal cord into the fourth ventricle. And there are theories suggesting that there's a Venturi effect, that Chiari malformation or spinal cord injury changes the velocity of CSF flow outside the spinal cord, and because of the Venturi principle, causes a change in pressure and expands the cord. And without going into the details, it's fairly clear that the physical principles required to substantiate these theories really just aren't there. So we know that those theories are not true either. And for most of the conditions that we see in association with syringomyelia, there is an abnormality in the subarachnoid space. And so is it always that there is some sort of obstruction in the subarachnoid space? Well, no, because in cases of spinal dysraphism, so tethered cord, this syrinx occurs when there's no abnormality in the subarachnoid space. There's no obstruction. So it's not always a problem in the subarachnoid space. And then we come to those where there is clearly a syrinx cavity, but we can never find any abnormality, subarachnoid space or elsewhere. And so it's really quite puzzling about how these occur. So to put that all together, we really don't know what causes syrinx cavities. None of those theories can really hold up to scrutiny. There is no theory that explains all the different types of syringomyelia, and no theory that explains the possibility that a syrinx cavity can have a higher pressure in it than the surrounding cord tissue or the surrounding subarachnoid space, which is, after all, what is necessary for a syrinx to enlarge, because a syrinx can't enlarge unless the pressure within it is greater than the pressure in the spinal cord, right? So it can't be that the pressure on the outside is greater than the syrinx, because the syrinx can sometimes get bigger. So I'm going to turn now to just a little overview of CSF physiology. And I know you all know this, but just to talk about it and how it might be relevant to syringomyelia. And I'll talk about how CSF is produced, absorbed, circulates, and then is spinal CSF physiology any different? And then what's the impact of pathology, Chiari malformation, spinal cord injury, on CSF physiology? You're all familiar with this type of diagram, which is our traditional understanding of CSF physiology, which says that CSF is produced by the choroid plexus, circulates through the ventricles, comes out in the subarachnoid space, and is absorbed into the venous sinuses. And in most of these kind of descriptions, the spinal subarachnoid space and spinal CSF circulation really doesn't get much of a mention. We just get this kind of diagram that says that some CSF is pushed into the spine, but there's really no further detail about that. The reality, though, is CSF physiology is a lot more complicated than that. And CSF it's very clear that CSF is produced not just by the choroid plexus. Yes, choroid plexus is involved, but I like this diagram because it represents how important the choroid plexus actually is, which is minimal. CSF is produced by the choroid plexus, but it is also produced throughout the central nervous system in the brain and the spinal cord. And yes, it is absorbed into the venous sinuses, but it is also absorbed into the vasculature throughout the brain and spinal cord and into lymphatic vessels. And so one way to summarize that is to say that CSF is produced everywhere and absorbed everywhere. It's this really complex system, not just the simple system that you would be led to believe with the diagram on the left. And I think that's illustrated with this case where this is a patient who's had a spinal cord injury, and I operated on him because he developed this large syrinx and became symptomatic from that. And at operation, we found that the dura here had been completely severed and healed separately, so that the rostral dura was completely separate from the caudal dura. And so I treated that patient by connecting the dural cavities of the subarachnoid spaces together again. But the subarachnoid space in the lumbar spine was completely normal. CSF, crystal clear CSF under normal pressure. It is clearly not coming from the brain because it's not connected. So it's being produced in the spine and being absorbed in the spine, and not from that traditional understanding of CSF physiology. And of course, we know that, yes, CSF is absorbed into venous sinuses, but in the spine, there are similar structures, arachnoid villi, around spinal nerve roots, and there are fairly complex lymphatic structures around the spine as well as the brain that are likely to be involved in CSF absorption. And what about the flow in the subarachnoid space? Well, again, we get this simplistic view, but it is more complicated than that, and particularly, what is it that's driving it? Is it arterial pulsations? Is it respiration? And what about in the spine? Well, this is just a more recent study just showing how complex the CSF circulation is in the spine. This is a study looking at what the impact of the dentate ligaments and nerve roots might be on the flow of CSF in the spine. It's incredibly complicated and complex. And I'm not going to go into any more detail other than to say that this is clearly an important field for further research to try and understand in more detail how spinal CSF circulates. There are influences on subarachnoid space flow. We know that it's not just our work, but work of other researchers as well, shows that arterial pulsations are very important, and that if you increase the heart rate, there's a change in CSF flow. But what has emerged in recent years is that respiration is more important as a driver of CSF flow than arterial pulsations. And that's true not just in the head, but in the spine. And this is just an example from some of our research where he has tagged CSF. So the high signal here is from a pulse, radiofrequency pulse. And we show using different respiratory maneuvers that respiration really pushes the CSF up and down much more than arterial pulsation does. And that coughing is a respiratory maneuver that has an even greater impact on CSF circulation. So coming back to, I suppose, that original theory of Williams suggesting that cough might be important, or of Ball and Dayan, but not in the way that they suggested. So cough is definitely an important driver of spinal subarachnoid fluid flow. And then we come to the so-called glymphatic system, which suggests that CSF comes in around arteries into the central nervous system. And most of this work has been done in the brain, but suggests that CSF has this unidirectional flow coming into the perivascular spaces, the Virchow-Robin spaces, around arteries, and that CSF then goes through the extracellular spaces of the brain, washing out toxins and proteins into perivascular spaces around veins, and then back out of the brain. Now, that's a pretty controversial subject, and our view is that it's certainly not that simple. But how does it work in the spine? Well, we showed, a long time ago that yes, CSF gets into the spinal cord into arterial perivascular spaces, and that this flow does depend on arterial pulsations, but it doesn't go out just around veins. And this is some of my early work showing that CSF actually goes from perivascular spaces in the spinal cord directly through between ependymal cells into the central canal. There is this circulation of CSF through the spinal cord into the central canal. And some of our recent work has revealed that, yes, arterial pulsations are important, but that respiration is actually the main driver of that flow. The flow of CSF into the spinal cord is much greater when the physiology is with a person alternating with positive and negative respiratory pressures than with other situations. And so respiration is an important driver of that CSF physiology into the cord. And then we look at, well, how does it get back out? Because if the CSF is coming in, it's got to get out. And what we showed is that in the outflow, it is actually the cardiac cycle that's the most important. Heart rate and blood pressure are the major influences on CSF outflow. So respiratory drives CSF in, blood pressure and heart rate drive CSF out. And of course, there's got to be a balance between those. And then if you come back to that glymphatic theory, well, you would have to believe that CSF is just coming in around arteries and out around veins. Well, we've shown in the spinal cord that that's not true. These are some of our fairly detailed studies showing that if we inject a tracer into the cord tissue, it comes out not just around veins, but also around arteries. And so here is the anterior spinal artery in cross section, and we know it's an artery because it's got smooth muscle cells in it. And the green is the CSF tracer. So it's actually coming out of the spinal cord around veins, but also around arteries and into the central canal. So it's clearly complex. So really just to put that together, CSF is produced everywhere, absorbed everywhere, including in the spine. The circulation in the spinal subarachnoid space is complex, but we know that respiration and arterial pulsations are important, and that there is no specific one-way circulation of CSF as the glymphatic people would have you believe. That does not happen in the spinal cord. So what about when there's subarachnoid space pathology, and in particular Chiari malformation and spinal cord injury with arachnoiditis? Well, we've shown that, of course, arachnoiditis affects the spinal cord flow, and it changes the pressure in the subarachnoid space. So it's almost as if the pressure builds up close to the point of the arachnoiditis. Of course, the overall pressure can't change. And in some of our experimental studies, we tie a ligature around the dura in an experimental animal and then inject tracers into the subarachnoid space. And what we show is that the tracer goes into the spinal cord more when there is constriction than when there is no constriction. So it's really fascinating. So that when there is an obstruction in the subarachnoid space, there is an increase of fluid flow into the spinal cord. So I think that goes a long way to helping us understand how a syrinx might form in the presence of arachnoiditis or other constrictive pathologies. This is just showing that histologically, so in control, green is the CSF tracer, it gets into the central canal, but when there is adjacent subarachnoid space constriction, the amount of CSF that gets into the cord is much greater. And then we've looked at the possibility that for Chiari malformation in particular, that the underlying pathology here, pathophysiology, might be that not that it's blocking CSF flow as such, but that it is altering the transmission of pulsations. So if the Chiari malformation delayed the transmission of pulsation from the head to the spine, then you might get a mismatch between the arterial pulsation reaching the spine through the arteries versus the CSF pulsation reaching the spine through the head. And if they're arriving at different times, then you might get a change in the CSF flow into the cord, or an increase in CSF flow into the cord. And sure enough, we've demonstrated that in the presence of Chiari malformation, there is a delay. And so that is a possible explanation for the development of syrinx cavity in the presence of Chiari malformation. So, a lot of times people will say that they're doing a Chiari operation to restore flow. It's probably more restoration of the transmission of pulsation rather than the actual flow. And this is just showing the impact of coughing in the presence of Chiari malformation. So we're able now in our experimental work to not only look at cardiac motion with Chiari malformation, but what happens with cough. And sure enough, when a person coughs, the Chiari malformation goes up. It pushes the tonsils up into the head rather than pushing them down, as Ball and Dayan suggested might have happened. And then we've done quite a few animal models looking at what happens with the CSF physiology. So we've got animal models of canalicular syringomyelia and post-traumatic extracanalicular syringomyelia. And in each of those models, we've shown that this perivascular flow is still the pathway for CSF to get into the cord, into the syrinx cavity. So it's coming from the subarachnoid space through the perivascular spaces, even as the syrinx cavity is enlarging and developing. So it must be this, there's an intriguing question there about how that happens when presumably the pressure in the syrinx cavity is larger than in the subarachnoid space for it to enlarge. Okay, so just to summarize that, we know that perivascular spaces are the inflow pathway from our experimental work. Exactly the driving forces remain a little bit unclear, but it's probably a combination of respiratory and cardiac effects. And that we know that subarachnoid space obstruction reduces the CSF flow in the subarachnoid space, but increases the flow into the cord. And it may be a phase difference that is the key underlying problem for Chiari malformation. Okay, so I know that you're probably all falling asleep listening to that part, so I'm going to go on now to some clinical stuff. So how does that thinking about all those things impact on how we manage syringomyelia? So as I said, for the craniocervical junction abnormalities, I think we're addressing pulse transmission rather than flow. And for the spine, the subarachnoid space obstruction is the key. Again, it's the pulsation, not the flow. And I'm going to show some examples that really point to this. And hopefully this is one of the takeaways, that if you do a syrinx to subarachnoid shunt, thinking about where the CSF gets absorbed from the subarachnoid space, which is into those venous structures and the lymphatic structures around nerve roots, for the CSF to get to those structures, it has to be in normal subarachnoid space. And so if you put in a shunt, the distal end of the shunt has to be in normal subarachnoid space. And it doesn't necessarily matter whether the shunt is directed rostrally or caudally, so long as it's in normal subarachnoid space without an element of obstruction. And I'll show some cases that illustrate that. We know, of course, that for Chiari malformation, there's a very varied technique, and that if you look at the reports in the literature, there's a variably high rate of persistent syrinx cavities. And that for post-traumatic syringomyelia or arachnoiditis syringomyelia, the surgery is even worse. And for idiopathic syrinxes, there's not really any very large convincing series to guide us as to how to manage those. One of the questions I always have is, well, what is the surgical goal? And often when we're treating Chiari malformation, we're treating headache, cognitive disturbance, perhaps brainstem compression. And I think for those, the compression is relieving the compression is the surgical goal. But when we're treating syringomyelia, what is the surgical goal? And because we don't really understand that pathology very well, it's hard, or I don't think it's possible for us to say what the surgical goal actually is. For me, I think it's restoring that transmission of pulsation. And then just to reiterate that most Chiari cases are non-communicating, but some of them are communicating. I showed you one before. Here's another couple. These are communicating syrinx cavities. And so the surgical goal for these is perhaps different, because for these, I think the pathophysiology is transmission of CSF down the central canal into the syrinx cavity. And so the surgical goal here is to get CSF out of the fourth ventricle, not so much to relieve compression from the Chiari malformation. And here's an example where the cerebellar tonsils, there's a membrane across the foramen majondi. This is the kind of case where you get a communicating syrinx. And so for me, every Chiari case, and especially those where there is a suggestion of a communicating syrinx, I explore the fourth ventricle because it is not uncommon to find this kind of abnormality. And when you do that, you deal with the CSF flow out of the fourth ventricle, then that will relieve the syrinx cavity. Sometimes it requires a shunt tube. So this is a ventricular catheter going from the fourth ventricle into the spinal subarachnoid space to make sure that that CSF gets out of the fourth ventricle so that the syrinx can collapse. And using this approach, I've, in well over 100 cases now of Chiari-associated Syringomyelia, I've had only one case where the syrinx didn't collapse. This is a child where the syrinx actually has got a little bit bigger. I'm still not sure why that is. He's got a skull base abnormality, so maybe that's related. But this approach has proved very successful apart from that case. And then, of course, we see patients where they've had craniocervical junction surgery done elsewhere. And here is a pseudomeningocele. And sometimes the original surgeon says, well, there's CSF space there. What more do you want? That's successful. Or this is a pseudomeningocele. There's tethering of the cerebellum to the overlying patch graft. This is obviously a terrible outcome. Again, tethering of the cerebellum to the overlying patch graft. And here's an example where someone has used Duragen as the patch graft. The Duragen just sticks onto the cerebellum, creates all this scarring, and the syrinx doesn't get better because it's just not relieving that transmission of pulsation. And often they will develop this scarring across the foramen majondi, and I find it's necessary to open that. And when that membrane is formed by scarring, I'll always put in a shunt tube because I think that the scarring is likely to reform otherwise. And so we've had experience with over 30 cases of revision surgery for Chiari and Syringomyelia. I've never had to do a revision case where the original patch graft was pericranium or Gore-Tex. I've only ever had to do revision surgery where the original surgery, not done by me, but done elsewhere, has used Duragen or some other artificial patch graft, or fascia lata, ligamentum nuchae, or where the dura has been left open. So techniques that lead to scar formation tend to be the ones where we need to do revision surgery. And we've had reasonable success with those. And then, of course, there's craniocervical junction arachnoiditis. So this is not Chiari malformation, but using our dynamic imaging, we can show that this is an arachnoid scar at the craniocervical junction. And in a sense, they're similar to Chiari malformation, but really what we're trying to deal with here is that scar tissue at the craniocervical junction. And if we deal with that, and often I put in a shunt to maintain the patency of that space, the syrinx will collapse. And we've had good success with that. When we did this study, it became really apparent that when there's craniocervical junction arachnoiditis, these are communicating syrinxes. And so it's all about getting the CSF out of the fourth ventricle down into normal spinal subarachnoid space. So you're using a catheter down into the spine where the subarachnoid space is normal. And then if we look at idiopathic Syringomyelia, as I said, there's not very many large series, really only small numbers of cases and a larger pediatric series. But it's said to account for 15 to 20% of syrinx cavities. So it's a relatively large number. What we've been focusing on is really trying to identify the underlying cause in these, and that comes to the imaging. So T1 is not very good at showing syrinx cavities. T2 is not very good at showing subarachnoid space pathology. Cardiac-gated phase contrast is pretty good at demonstrating CSF motion, but not really very good at demonstrating the actual anatomical substrate for abnormalities. And so we find that our cardiac-gated balanced fast field echo, or Fiesta, can usually demonstrate, I hope that's showing, there's an arachnoid membrane here that's being demonstrated not so well on the plain T2, but very clearly on that dynamic scan. We can see the arachnoid pathology using that. And this is that case. Intraoperative ultrasound shows that arachnoid pathology very clearly. When we divide that arachnoid band, it's apparent that the CSF space is separate, rostral and caudal, and resecting that membrane is generally sufficient. Although for many of these cases, I'll put a shunt in from the syrinx cavity to the spinal subarachnoid space, because that's relatively easy when the syrinx is very superficial like that. And I think it provides an extra degree of long-term success. So that's this patient, and that's after division of the arachnoid pathology and insertion of the syrinx to subarachnoid shunt. Sometimes we still can't find it. So even with our dynamic scans, because the syrinx has expanded the cord, we can't see the subarachnoid space. And at operation, the subarachnoid space looked completely normal, apart from the cord being enlarged. Once we put in a shunt, the syrinx, the cord collapsed, but we were not able to identify any arachnoid pathology. So there are still some cases where they come under the title of idiopathic, and we don't really understand what's causing those. And I'm sure many of you see this kind of case with the thoracic syrinx cavities. This is a patient. The top two images are the same patient before surgery. She's got two syrinx cavities, thoracic and cervical and thoracic. And she is symptomatic from the thoracic syrinx cavity. And I put in a thoracic syrinx to subarachnoid shunt, and of course, both syrinx cavities reduce in size. And this is a general rule. When you've got multiple syrinx cavities like this, if you treat one, they will all collapse. So that I think the fluid is communicating through the spinal cord. And then I found this is an interesting case because in my experience, syringomyelia resulting from extradural constriction is really very rare. And I know that if you look at this case, you would say, well, this syrinx is caused by the extradural constriction from that disc protrusion and ligamentum flavum hypertrophy here. That's clearly the cause. But she had a scan done 9 years earlier, and she had the syrinx cavity there before she developed that extradural constriction. So this is not caused by the extradural constriction. And we've treated her with a syrinx to subarachnoid shunt rather than perhaps treating the disc protrusion. So here, this is syrinx to subarachnoid shunt. Syrinx has collapsed, and she's improved clinically. This case was very illustrative for me. This is a person who had a spontaneous spinal subarachnoid hemorrhage. So he's got hemorrhage-induced arachnoiditis through the subarachnoid space, and we used our dynamic scans to identify the location of the scarring. And I suggested to him that he have surgery at this stage, and he refused. And it wasn't until a year later that he became more symptomatic. The syrinx cavity is now more well-defined and larger. There's edema through the cord. And our dynamic imaging suggested that there was arachnoiditis in this region. And that's where we operated. And I divided the arachnoid adhesions, put in a syrinx to subarachnoid shunt. But this illustrates the importance of getting this shunt beyond any obstruction, because what happened was 10 days post-operatively, he came back with worsening symptoms, and his syrinx was actually bigger. And that's because I had not appreciated that there was an additional region of arachnoiditis here. So what we've got is that arachnoid constriction. There is an increase in CSF pressure here that is going into the shunt. So my shunt actually made him worse. And the way that I managed that was to leave that shunt where it was and just put a new shunt in the subarachnoid space across that lower region of arachnoid adhesion. So now that subarachnoid space is communicating across there, and the syrinx collapses. And so the message here is when you put in a shunt, the distal end, it doesn't have to, if it goes up, that's okay if the spinal subarachnoid space is normal. But if there is a level of obstruction, the distal end of the catheter has to go caudal to that level of obstruction. Okay, this is just another example of an arachnoid membrane that's clearly demonstrated on the dynamic imaging not so clearly seen on the static T2 MR. This is a case, again, hemorrhage. This person had a subarachnoid hemorrhage from a posterior circulation aneurysm, developed this complex syrinx. We dealt with that by dividing the arachnoid adhesions and putting in a subarachnoid shunt. So the shunt just goes across where the arachnoid adhesions were, hoping to keep that subarachnoid space open. And that was sufficient to deal with the syrinx cavity. This is another subarachnoid hemorrhage-induced syrinx with cord edema. This case has very extensive arachnoiditis, and so I don't think surgery is likely to be helpful for this patient. Luckily, she has stayed stable, but that would be a very difficult problem to deal with surgically. We'd have to try and get communication from this subarachnoid space to this subarachnoid space. So it's a very large, would be a very large operation that would be required in an elderly patient. So some of these cases are really just not able to be treated. Then just for post-traumatic cases, I know that a lot of people have a focus on making sure there's division of all the arachnoid adhesions. For me, it's really about getting, I generally put in a shunt and get that shunt distal to the adhesions, knowing, of course, that the adhesions are likely to reform. So having the shunt is important. This is another really important case in my experience where this is a young woman who's had a spinal cord injury, 2011. By 2017, she had this syrinx cavity, and she had it treated elsewhere. So not by me, treated in another hospital. And the syrinx cavity did not get better. And I'll explain why. Here are the cross sections. So there is the shunt. They put a shunt, that's the shunt, in the syrinx cavity, and they put it down in the spine. There is the syrinx shunt. Here is the shunt outside the cord. And what's happened is they've put that shunt in the subdural space, not in the subarachnoid space. And of course, when CSF gets into the subdural space, it has no access to the absorption mechanisms in the spine. Bearing in mind, the absorption mechanisms are around spinal nerve roots. And so for the CSF to get into the spinal nerve roots, it has to be in the subarachnoid space. And so the solution for this patient was just to reposition that shunt tube from the subdural space. This is all CSF in a subdural collection with the nerve roots and the cauda equina all squashed together. And here I've opened that subdural collection. Here is the shunt in what is a sort of subdural neo arachnoid collection. I'm opening the arachnoid into the normal subarachnoid space, put that syrinx shunt into the normal subarachnoid space around the cauda equina nerve roots, and the syrinx collapses. And that's because the CSF is able to get out of the shunt and get absorbed. So the big lesson there is when you're opening the dura, what I do is keep the arachnoid up against the dura. I'll use Liggy clips to keep the arachnoid up against the dura so that when I come to close, the arachnoid doesn't collapse and I don't get trapped into putting a shunt into the gap between the arachnoid layer and the dural layer. This is my experience with syrinx shunts for a range of conditions. I prefer a midline approach, and I put it where the syrinx is maximum size, but trying to get it as low down in the cord as possible. I like for the midline, the distance between the surface of the cord and the syrinx to be less than 2 millimeters. I use lumboperitoneal shunts, which have an outside diameter of 1.1 or 1.3 millimeters. And it doesn't matter which direction the shunt goes, so long as it's into normal subarachnoid space. I try to get the shunt holes from the catheter in and out of the cord, and I secure it with 8-0 nylon. I usually don't use a duroplasty. And this is just an example. So here, opening the dura, and then you'll see when I open the arachnoid, so retracting the dura, open the arachnoid, and to make sure that I preserve that subarachnoid space and don't create a subdural space, I clip the arachnoid up to the dural edges. And then when I close the dura, I put the sutures through the arachnoid as well. I'm sure many of you will do this, but just making sure that the arachnoid is preserved in that way. I make sure that there's communication with the ventral subarachnoid space. Identify the midline by finding where these vessels penetrate into the cord. So see that they all line up. So penetration of vessel into the cord, that's the midline. So here I've decided to put the shunt in here into this location. I'm mobilizing the vein by just dividing that arachnoid around it. I can move the vein to that dorsal vein to the side, use an ophthalmic knife to make a midline peel incision. And then the Roton small round knife I find really useful to develop that plane rather than putting the forceps in initially, because you put the forceps in initially, you damage the dorsal, the white matter fibers. So I developed that plane first using the round knife and then use the forceps to spread. There's the syrinx cavity. We're entering just under 2 millimeters in depth. And then you'll see I put here's the lumboperitoneal catheter, and I'm deliberately wriggling it. So it looks like I've got a tremor, but it's not a tremor. I'm just wriggling it in to get through that small myelotomy. And in this case, this is the rostral subarachnoid space. That's the caudal subarachnoid space. It just happened to fit much better that way. And so this catheter is being directed caudally into the syrinx cavity, and then just making sure that that distal end gets into the subarachnoid space. And when I close the dura, close the arachnoid over the top of that, making sure that that catheter doesn't get into that subdural space. And then secure that to the dura using 18 nylon. And our syrinx subarachnoid shunts have been quite successful. I've had to revise a couple, and I've changed to an 8-0 suture rather than a 9-0 suture. And I haven't had to revise any since I've done that. So just to finish off, we still don't really understand CSF pathophysiology. It's important to identify subarachnoid space pathology wherever possible. Extensive arachnoiditis is really difficult. Small idiopathic syrinx cavities, that's really difficult to treat because you can't find the cause, you can't treat them. And as I say, trying to understand syrinx pathophysiology, I think, remains the key for us to advance the way that we treat these patients. And as Celine said, we've had a lot of support from funding organizations to do the research that we've done. And it's been a large team that's been involved. So there we are. And thank you for your attention.
Thank you, Professor, for detailed presentation. I got answers to almost all my questions during the presentation. Just one question from me. I wonder about pregnancies and labor in women with Syringomyelia. I think the experience is limited and the literature is limited about it. Do you recommend normal or cesarean section delivery in women with Syringomyelia?
Yeah, that's a really important question, isn't it? Can I answer first for Chiari malformation? Because I think these are two different things. So if a person has Chiari malformation with no syrinx, then a lot of people will advise them not to have a vaginal delivery because they're worried about the pressure changes when they're pushing. Whereas there's actually really very good studies showing there's no concern there at all. My only concern is if they have an epidural anesthetic or a spinal anesthetic, and there is a dural puncture, and then CSF comes out, the tonsils can descend quite quickly, and then that can be terrible. So I know of disasters where people have developed quadriplegia or even died in that circumstance. So for people with severe Chiari malformation, I will generally advise them, it doesn't matter what form of delivery, but they can't have spinal anesthesia because that's the concern. Now, for a syrinx cavity, if it's a small syrinx cavity that's not symptomatic, I'm not too concerned about that. But if it's a large cavity, and I had a patient like this actually just this week, came with, she's not symptomatic from the syrinx, and so we're not treating her, but she's got quite a large syrinx cavity, like some of those I showed in the talk, where, big expansion of the central canal. The concern there is that any Valsalva maneuvers, so coughing, sneezing, and straining, so pushing in pregnancy, in delivery, increases the pressure And then that if it's a sudden change, it can impact on the cord. And then what happens is the syrinx dissects. It does that dissection into the surrounding cord tissue. And I'm sure you've all seen patients who present not having had symptoms, but then they've had a respiratory illness, lots of coughing, sneezing, COVID, and now they've got numbness and weakness in the upper limbs. So for me, that's where I tell in the case of pregnancy, that probably they should avoid natural delivery to avoid the pushing. But there's not very many cases.
Thank you, Professor. And I'll direct the questions to you from participants. First question from Professor Suju, and he thanked. Amazing videos. Thank you for sharing. And thank you for your didactic lecture. And question is, how many % of idiopathic Syringomyelia cases are communicating Syringomyelia cases? And how many % of idiopathic Syringomyelia require treatment?
So I think for the communicating ones, it's probably none are idiopathic, because they must, to be communicating, they must have obstruction of the outlets of the fourth ventricle. And I think if you've got a communicating syrinx, and if you operate at the fourth ventricle, you'll find the obstruction of the outlets of the fourth ventricle. For the requiring treatment, it's very much the minority, isn't it? I mean, because the problem, of course, is that we all see, particularly in the thoracic cord, slightly enlarged central canal. When is it a syrinx? When is it not a syrinx? You know, that's hard to say. Certainly the majority of patients that get referred for me to assess, where they've had a scan that shows a syrinx that we might call idiopathic, the vast majority of those are not symptomatic, and we don't treat them.
Thank you. And a question and thanks from Professor Haluk Berk. Thank you for wonderful lecture. What is your impression on increased scoliosis in Chiari and also idiopathic Syringomyelia? How many scoliosis were there in your 100 Chiari cases, if any? Finally, did you observe regression of scoliosis after managing syrinx? He asked.
Yes. So there is a fair bit of research that's been published on these questions. And what's interesting to me is that even for patients with Chiari malformation without syringomyelia, they have an increased incidence of scoliosis. Now, whether that's because there's compression on the upper cord and so there's some slight imbalance of the function of the pathways, it's hard to say. But certainly for the syrinx cases, there's no doubt that syringomyelia is a cause of scoliosis, particularly in children. And it's when there is some sort of dissection into the cord tissue and any kind of imbalance of muscle tone, of axial muscle tone, will result in scoliosis. What we know from the research that has been published is that the scoliosis outcomes are better if you treat the syrinx. Not in every case, though. So sometimes you treat the syrinx and the scoliosis will still progress. But I've certainly had cases where the scoliosis improves when you treat the syrinx. So I think the way to approach these patients is to say that your best chance to manage the scoliosis is to treat the syrinx, but there are no promises.
Thank you. And as far as I can see, there are no further questions. Thanks again. I give the turn to Professor Suji for the closing speech.
There is one more question, but
I couldn't.
it is written directly to me, and I will read it from Ayman. Thank you, Professor Stoodley. I am a neurosurgery resident from Kazakhstan. Where is the exact place of shunt attachment and where it is draining to? I also wonder about pediatric cases. Here we prefer to observe if it is asymptomatic. What is your experience? And the last question I have about Chiari and Syringomyelia. Do you perform first posterior fossa decompression and the second stage operation for Syringomyelia, or as a one-time operation? Maybe do you also observe for a resolution after decompression? I think
So
it
there's
is
a few questions.
3 questions.
Yes, so I've got to try to remember them all. So for the Chiari associated, when there's Chiari plus syrinx, in my experience, as I say, I've had well over 100 cases of Chiari associated syrinx. And if I operate on the Chiari, the syrinx gets better. I've had one case where it didn't get better. So I've never had to shunt a syrinx after doing a Chiari operation. With the other questions, I wouldn't, I don't treat asymptomatic syrinxes generally, unless there's a symptomatic Chiari, or if there's evidence of dissection into the cord, or if there's, well, scoliosis, I guess, is really symptomatic. So there'd have to be a reason. So don't generally treat asymptomatic cases, and especially pediatric ones. So if there's a pediatric case that's not symptomatic, then there wouldn't really be an indication for treatment. And then for the shunt attachment, so as I say, I put all my syrinx shunts into the spinal subarachnoid space. So they're draining into, they don't go to the pleural cavity, they don't go to the peritoneal cavity, they're in the spinal subarachnoid space. And I secure them to the inner surface of the dura using an ATO nylon. So through the shunt tube, and then through the inner surface of the dura, and then just tie it. So just to stop the syrinx, the shunt from moving up and down. I hope that answers all those questions.
Okay, Ayman, is it enough for you? You can ask by yourself also.
Yes, thank you for answering my questions, Professor Stoodley. I really enjoyed your presentation, and thank you for explaining pathophysiological concepts also.
You're welcome.
Thank you, Ayman. Okay, Selin, I think we finished all the questions and comments, and thanks. I want to thank again Professor Marcus Stoodley. It was a wonderful lecture indeed, and he explained all the things about. Oh, there is one more. Thanks from Kumar. I think he is from India. Thanks. Well illustrative. Nepal. Oh, sorry. He is from Nepal. And we reached, at its maximum, we reached 44 participants today. Not so bad for a weekend, actually. Everyone is walking around, visiting some places. Thanks again, Professor, and I want to thank everyone who joined us today from different countries, Georgia and Nepal and others. Thank you very much.
You're most welcome.